Okay, you may start now.
Good day, everyone. The topic to discuss is all about liver functions. The liver performs essential, life-sustaining functions. Let me ask you, can we live without liver? Well, we can't live without the liver completely. We can live with only part of one. Many people can function well with just under half of their liver. Liver plays a vital role because without the liver, our blood won't properly clot, causing uncontrolled bleeding toxins and chemical and digestive byproducts will build up in the blood. We will have fewer defenses against bacterial and fungal infections, and also we can have swelling, including deadly swelling of the brain. I am Michelle Asotilia, the first presenter. Next. Next lang. And here is the liver functions outline. We have the anatomy, biochemical functions, liver functions alteration during disease, assessment of liver functions or liver function test, and the methods. Next. The liver function objectives. We have illustrating the diagram of the anatomy of the liver, explaining the following functions of the liver: bile secretion, synthetic activity, and detoxification. List two important cell types associated with the liver and state the function of each. Define jaundice and classify the three different types of jaundice, discussing the basic disorders of the liver and which laboratory tests may be performed to diagnose them, evaluating liver-related data and correlate that data with normal or pathologic states, comparing and contrasting how total and direct bilirubin measurements are performed, the list of the enzyme most commonly used to assess hepatocellular and hepatobiliary biliary disorders, describing the various types of hepatitis to include cause, transmission, occurrence, alternate name, pathology, diagnosis, and treatment. Next. And here are the key terms, and you must be attentive because later on, all of this will discuss. So be attentive. Next. Next lang.
Okay na po.
So now we have the anatomy, the gross anatomy. We have two different anatomy. We have the gross anatomy and microscopic anatomy. So for the gross anatomy, understanding the function and dysfunction of the liver depends on understanding its gross and microscopic structure. So the liver is a large and complex organ weighing approximately 1.2 to 1.5 kilogram in the healthy adult. It is located beneath and attached to the diaphragm. That is protected by the lower rib cage and is held in place by ligamentous attachments. Despite the functional complexity of the liver, it is relatively simple in structure. So it is divided unequally into two lobes by the falciparum ligament, the right lobe and the left lobe. So the right lobe is approximately 6 times larger than the left lobe. The lobes are functionally insignificant. However, communication flows freely between all areas of the liver. Next.
Okay na, Mi.
Unlike most organs which have a single blood supply, the liver is an extremely vascular organ that receives its blood supply from two major sources. We have the hepatic artery and the portal vein. The hepatic artery, it is a branch of the aorta. It supplies oxygen-rich blood from the heart to the liver and is responsible for providing approximately 25% of the total blood supply to the liver. Meanwhile, the portal vein, it supplies nutrients-rich blood or collected as food is digested from the digestive tract, and it is responsible for providing approximately 75% of the total blood supply to the liver. So the two blood supply eventually merge into the hepatic sinusoid, which is lined with hepatocytes capable of removing potentially toxic substances from the blood. So from the sinusoid, blood flows to the central canal or central vein of each lobule. It is through the central canal that blood leaves the liver, and it is approximately 1,500 ml of blood passes through the liver per minute. So the liver is drained by a collecting system of veins that empties into the hepatic veins and ultimately into the inferior vena cava. Next. The excretory system of the liver begins at the bile canaliculi. The bile canaliculi are small spaces between the hepatocytes that form intrahepatic ducts, where excretory products of the cells can drain. The intrahepatic ducts join to form the right and left hepatic ducts, which drain the secretions from the liver. The right and left hepatic ducts merge to form the common hepatic duct, which is eventually joined with the cystic duct of the gallbladder to form the common bile duct. So combined digestive secretions are then expelled into the duodenum. Next. This is the microscopic anatomy. So the liver is divided into microscopic units called lobules. So the lobules are the functional units of the liver, responsible for all metabolic and excretory functions performed by the liver. So each lobule is roughly a six-sided structure with a centrally located vein called the central vein, with portal triads at each of the corners. So each portal triad contains a hepatic artery, a portal vein, and a bile duct surrounded by connective tissue. The liver contains two major cell types. We have the hepatocytes and Kupffer cells. The hepatocytes making up approximately 80% of the volume of the organ. And it is large cells that radiate outward in plates but from the central vein to the periphery of the lobule. These cells perform the major functions associated with the liver and are responsible for the regenerative properties of the liver. Meanwhile, the Kupffer cells, these are the macrophages that line the sinusoids of the liver and act as active phagocytes capable of engulfing bacteria, debris, toxins, and other substances flowing through the sinusoids. Next. Here are the biochemical functions. We have four major functions of the liver. First, we have the excretion or secretion, metabolism, detoxification, and storage. Next. The liver is so important that if the liver becomes non-functional, death will occur within 24 hours due to hypoglycemia. Although the liver is responsible for a number of functions. So now we are down to excretory and secretory. So one of the most important functions of the liver is the processing and excretions of endogenous and exogenous substances into the bile or urine, such as the major heme waste product, bilirubin. The liver is the only organ that has the capacity to read the body of heme waste products. So bile is made up of the bile acids or salts, bile pigments, cholesterol, and other substances extracted from the blood. The body produces approximately 3 liters of bile per day and excretes 1 liter of what is produced. So the bilirubin is the principal pigment in bile, and it is derived from the breakdown of red blood cells. Approximately 126 days after the emergence from the reticuloendothelial tissue, red blood cells are phagocytized and hemoglobin is released. Next. Hemoglobin is degraded to heme, globin, and iron. The iron is bound by transfer in the liver or bone marrow for reuse. The globin is degraded to its constituent amino acids, which are reused by the body. So the heme portion of hemoglobin is converted to bilirubin in 2 to 3 hours. Bilirubin is bound by Next. This form of bilirubin is referred to as unconjugated or direct bilirubin. Unconjugated bilirubin is insoluble in water and cannot be removed from the body until it has been conjugated by the liver. Once at the liver cell, unconjugated bilirubin flows into these sinusoidal spaces and is released from albumin, so it can be picked up by a carrier protein called ligandin. Ligandin, which is located in the hepatocytes, and it is responsible for transporting unconjugated bilirubin to the endoplasmic reticulum, where it may be rapidly conjugated. The conjugation or esterification of bilirubin occurs in the presence of the enzyme uridine diphosphate glucuronyl transferase or UDPGT, which transfers a glucuronic acid molecule to each of the two propionic acid side chains of bilirubin to form bilirubin diglucuronide and also known as conjugated bilirubin. So conjugated bilirubin is water soluble and is be able to secreted from the hepatocyte into the bile canaliculi. Next. Once in the hepatic duct, it combines with secretions from the gallbladder through the cystic duct and is expelled through the common bile duct to the intestine. So the intestinal bacteria, especially the bacteria in the lower portion of the intestinal tract, work on conjugated bilirubin to produce mesobilirubin, which is reduced to form mesobilirubinogen and then urobilinogen, or a colorless product. Most of the urobilinogen form roughly 80%, and it is oxidized to an orange-colored product called urobilin or stercobilin, and it is excreted in the feces. The urobilin or stercobilin is what gives stool its brown color. There are two things that can happen to the remaining 20% of urobilinogen form. The majority will be absorbed by extrahepatic circulation to be recycled through the liver and re-excreted. So the other very small quantity left will enter systemic circulation and will subsequently be filtered by the kidney and excreted in the urine. And it is approximately 200 to 300 milligrams of bilirubin is produced per day. So it takes a normal functioning liver to process the bilirubin and eliminate it from the body. So this, as stated earlier, requires the bilirubin be conjugated. Almost of all the bilirubin form is eliminated in the feces, and a small amount of the colorless product urobilinogen is excreted in the urine. So the healthy adult has very low levels of total bilirubin. We have 0.2 to 1.0 milligram or BL in this serum, and of this amount, the majority is in the unconjugated form. Next. So now we have the second, the metabolism. So the liver has extensive metabolic capacity. It is responsible for metabolizing many biological compounds, including carbohydrates, lipids, and proteins. So the metabolism of carbohydrates is one of the most important functions of the liver. When carbohydrates are ingested and absorbed, the liver can do three things. We have the use of glucose for its own cellular energy requirements, circulate the glucose for use at the peripheral tissues, or to store glucose as glycogen, or principal storage form of glucose within the liver itself or within other tissues. So the liver is the major player in maintaining stable glucose concentrations due to its ability to store glucose as glycogen, or otherwise known as glycogenesis, and degrade glycogen or glycogenolysis depending on the body's needs. So under conditions of stress or in fasting state, when there is an increased requirement for glucose, the liver will break down stored glycogen or glycogenolysis. And when the supply of glycogen becomes depleted, the liver will create glucose from non-sugar carbon substrates like pyruvate, lactate, and amino acids or gluconeogenesis. So lipids are metabolized in the liver under normal circumstances when nutrition is adequate and demand for glucose is being met. So the liver is responsible for metabolizing both lipids and the lipoproteins and is responsible for gathering free fatty acids from the diet and those produced by the liver itself and breaking them down into glucose and cholesterol. So despite popular belief, the greatest source of cholesterol in the body comes from what is produced by the liver, not from dietary sources. So in fact, approximately 70% of the daily production of cholesterol, or roughly 1.5 to 2.0 grams, is produced by the liver. So almost all proteins are synthesized by the liver except for the immunoglobulins and adult hemoglobin. So the liver plays an essential role in development of hemoglobin in infants. So one of the most important proteins synthesized by the liver is albumin. Yes, which carries with it a wide range of important functions. The liver is also responsible for synthesizing the positive and negative acute phase reactants and coagulation proteins. And it is also serves to store a pool of amino acids through protein degradation. So the most critical aspects of protein metabolism includes transamination and deaminations of amino acids. So transamination results in transamination via a transaminase results in the exchange of the amino group on one acid with a ketone group or another acid. So after transamination, deamination degrades them to produce ammonium ions that are consumed in the synthesis of urea, and urea is excreted by the kidneys. So although it would seem logical that any damage to the liver would result in a loss of synthetic and metabolic functions of the liver, that is not the case. So the liver must be extensively impaired before it loses its ability to perform these essential functions. Next. So next we have the detoxification and drug metabolism. The liver serves as a gatekeeper between substances absorbed by the gastrointestinal tract and those released into systemic circulation. So every substance that is absorbed in the gastrointestinal tract must first pass through the liver. This is referred to as first pass. So this is an important function of the liver because it can allow important substances to reach the systemic circulation and can serve a barrier to prevent toxic or harmful substances from reaching systemic circulation. So the body has two mechanisms for detoxification of foreign materials or drugs and potions and metabolic products or bilirubin and ammonia. Either it may bind the material reversibly to inactivate the compound, or it may chemically modify the compound so it can be excreted in its chemically modified form. So one of the most important functions of the liver is the drug metabolizing system of the liver. So this system is responsible for the detoxification of many drugs through oxidation, reductions, hydrolysis, hydroxylation, carboxylation, and demethylation. Many of these take place in the liver microsomes via the cytochrome P450 isoenzymes. Done ako.
So good afternoon, ma'am. By the way, I'm Vanessa Jen P. Batua. So moving on to the liver functional alteration during disease. We have here the first disease, which is called jaundice. Jaundice is a French word, comes from the French word jaune, which means yellow, and it is one of the oldest known pathologic conditions reported, having been described by Hippocratic physicians. Jaundice or icterus is used to describe the yellow discoloration of the skin, eyes, and mucous membrane, most often resulting from the retention of bilirubin. However, it may also occur due to the retention of other substances. Although the upper limit of normal for total bilirubin is 1.0 to 1.5 milligram per dl, jaundice is usually not noticeable to the naked eye, and it is known as the overt jaundice, and until bilirubin level reach a 3.0 to 5.0 milligram per dl. Although the term jaundice and icterus are used interchangeably, the term icterus is not most commonly used in the clinical laboratory to refer to a serum or plasma sample with a yellow discoloration due to an elevated bilirubin level. Jaundice is most commonly classified based on the site of the disorder. And we have here the classification of jaundice. We have the prehepatic jaundice treatment. OMG, namatay tayo. So moving on to the liver function alteration during disease. By the way, good afternoon, ma'am. I'm Vanessa Jen P. Batua, reporting for this paste. The first disease is the jaundice. Jaundice, or the word jaundice, comes from the French word jaune, which means yellow, and it is one of the oldest pathologic conditions reported, having been described by Hippocratic physicians. Jaundice or icterus is used to describe the yellow discoloration of the skin, eyes, and mucous membranes, most often resulting from the retention of bilirubin. However, it may also occur due to the retention of other substances. Although the upper limit of normal for total bilirubin is 1.0 to 1.5 milligram per dl, jaundice is usually not noticeable to the naked eye, and it is known as overt jaundice. And then until bilirubin level reach 3.0 to 5.0 milligram per dl. Although the term jaundice and icterus are used interchangeably, the term icterus is most commonly used in the clinical laboratory to refer to a serum or plasma sample with a yellow discoloration due to an elevated bilirubin level. A jaundice is most commonly classified based on the site of the disorder, which is the prehepatic jaundice, hepatic jaundice, in the last posthepatic jaundice. And this classification is important because knowing the classification of jaundice will aid healthcare providers in formulating an appropriate treatment or management plan. Moving on. So here's the three classification of the jaundice. First is the prehepatic jaundice. Prehepatic and posthepatic jaundice, as the names imply, are caused by abnormalities outside the liver, either before as in prehepatic or after as in posthepatic. And in these conditions, liver function is normal or it may be functioning at a maximum to compensate for abnormalities occurring elsewhere. This is not the case with hepatic jaundice, where the jaundice is due to a problem with the liver itself, an intrinsic liver defect or disease. So moving on to the prehepatic jaundice. A prehepatic jaundice occurs when the problem causing the jaundice occurs prior to liver metabolism, and it is most commonly caused by an increased amount of bilirubin being presented to the liver, such as that seen in acute and chronic hemolytic anemias. A hemolytic anemia causes an increased amount of red blood cell destruction and the subsequent release of increased amounts of bilirubin presented to the liver for processing. The liver responds by functioning at maximum capacity. Therefore, people with prehepatic jaundice rarely have bilirubin levels that exceed 5.0 milligram per DL. Is it because the liver is capable of handling the overload? And this type of jaundice may also be referred to as a unconjugated hyperbilirubinemia, because the fraction of the bilirubin increase in people with prehepatic jaundice is the unconjugated fraction. This fraction of bilirubin, unconjugated bilirubin, is not water soluble, is bound to albumin, and it is not filtered by the kidneys and is not seen in the urine. Next is the hepatic jaundice. A hepatic jaundice occurs when the primary problem causing the jaundice resides in the liver. This is the intrinsic liver defect or disease. And this intrinsic liver defect or disease can be due to disorders of bilirubin metabolism and transport defect. A Crigler-Najjar syndrome, Darwin-Jansen syndrome, Gilbert's disease, and neonatal physiologic jaundice of the newborn, or due to the diseases resulting in hepatocellular injury or destruction. Gilbert disease, Crigler-Najjar syndrome, and physiologic jaundice of the newborn are hepatic causes of jaundice that result in elevation in the unconjugated bilirubin. Conditions such as Darwin-Jansen and Rotor syndrome are hepatic causes of jaundice that result in elevation and conjugated bilirubin. Gilbert syndrome was first described in the early 28th century. Is a benign autosomal recessive hereditary disorder that affects approximately 5% of the US population. A Gilbert syndrome results from a genetic mutation in the UGT1A1 gene that produces the enzyme uridine diphosphate glucuronosyltransferase, or the UDPGT. Is one of the enzymes important for bilirubin metabolism. The UGT1A1 gene is located on the chromosome 2. Another mutation of this same gene produces Crigler-Najjar syndrome, a more severe and a dangerous form of hyperbilirubinemia. Of the many causes of jaundice, Gilbert syndrome is the most common cause, and interestingly, it carries no morbidity or mortality in the majority of those affected and carries generally no clinical consequences. And it is characterized by intermittent and conjugated hyperbilirubinemia, underlying liver disease due to a defective conjugation system, and the absence of hemolysis. The hyperbilirubinemia usually manifests during the adolescence or early adulthood. Total serum bilirubin usually fluctuate between 1.5 and 3.0 milligram per DL, and it rarely exceeds 4.5 milligram per DL. And the molecular basis of Gilbert's syndrome in whites is related to the uridine diphosphate glucuronil transferase, or the UDPGT superfamily, which is responsible for the encoding enzymes that catalyze the conjugation of bilirubin. The UGT1A1, the hepatic 1A1 isoform of the UDPGT, contributes substantially to the process of conjugating bilirubin. The UGT1A1 promoter contains the sequence TA or 60AA. The insertion of an extra TA in the sequence, as seen in Gilbert syndrome, reduces the expression of the UGT1A1 gene to 20 to 30% of normal values. That is, the liver's conjugation system in Gilbert syndrome is working at approximately 30% of normal. Next is the Kregler-Nahar syndrome. Kregler-Nahar syndrome was first described by Kregler and Nahar in 1952 as a syndrome of chronic non-hemolytic unconjugated hyperbilirubinemia. Excuse me. Kregler-Nahar syndrome, like Gilbert syndromes, is an inherited disorder of bilirubin metabolism resulting from a molecular defect within the gene involved with bilirubin conjugation. The Kregler-Nahar syndrome may be divided into two types. We have the type 1, where there is a complete absence of enzymatic bilirubin conjugation, whereas the type 2, where there is a mutation causing a severe deficiency of the enzyme responsible for bilirubin conjugation. Unlike Gilbert syndrome, Kregler-Nahar syndrome is rare and is a more serious disorder that may result in death. While Gilbert disease and Kregler-Nahar syndrome are characterized as primarily unconjugated hyperbilirubinemias, Dowen-Johnson syndrome Dowen-Johnson syndrome and Rotor syndrome are characterized as conjugated hyperbilirubinemias. A Dowen-Johnson syndrome is a rare autosomal recessive inherited disorder caused by a deficiency of the canalicular multidrug resistance or multi-specific organic anionic transporter protein, or MDR2/CMOAT. In other words, the liver's ability to uptake and conjugate bilirubin is functional. However, the removal of conjugated bilirubin from the liver cell and the excretion into the bile are defective, and this results in accumulation of conjugated and to some extent unconjugated bilirubin in the blood, leading to hyperbilirubinemia and bilirubinuria. Dowen-Johnson is a condition that is obstructive in nature. So much of the conjugated bilirubin circulates bound to albumin. And this type of bilirubin, conjugated bilirubin bound to albumin, is referred to as the delta bilirubin. An increase in delta bilirubin possess a problem in laboratory evaluation because the delta bilirubin fraction reacts as conjugated bilirubin in the laboratory method to measure conjugated or direct bilirubin. A distinguishing feature of Dowen-Johnson syndrome is the appearance of the dark-stained granules thought to be the pigmented lysosome on a liver biopsy sample. Usually, the total bilirubin concentration remains between 2 and 5 milligram per DL, with more than 50% due to the conjugated fraction. And this syndrome is relatively mild in nature with an excellent prognosis. People with Dowen-Johnson syndrome have a normal life expectancy, so no treatment is necessary. Moving on to the Rotor syndrome. Rotor's syndrome is clinically similar to Dowen-Johnson syndrome, but the defect causing Rotor syndrome is not known or unknown. It is hypothesized to be due to it is hypothesized to be due to a reduction in the concentration or activity of intracellular binding proteins such as the ligandin. Unlike in Darwin-Johnson syndrome, a liver biopsy does not show dark pigmented granules. A Rotor syndrome is seen less commonly than Darwin-Johnson syndrome. It is a relatively benign condition and carries an excellent prognosis, and therefore treatment is not warranted. However, an accurate diagnosis is required to aid in distinguishing it from more serious liver disease than that require treatment. So a physiologic jaundice of the newborn. Moving on to the physiologic jaundice of the newborn. Physiologic jaundice of the newborn is a result of a deficiency in the enzyme UDPGT, one of the last liver functions to be activated in prenatal life, since bilirubin processing is handled by the mother of the fetus. A premature infant may be born without UDPGT, the enzyme responsible, which is the enzyme responsible for bilirubin conjugation. And this deficiency results in the rapid buildup of unconjugated bilirubin, which can be life-threatening. When unconjugated bilirubin builds up in the neonate, it cannot be processed and it is deposited in the nuclei of brain and degenerate nerve cells, causing kernicterus. A kernicterus often results in a cell damage and death in the newborn, and this condition will continue until UDPGT is produced. And infants with this type jaundice are usually treated with phototherapy to destroy the bilirubin as it passes through the capillaries of the skin. So, since it was described in 1958, phototherapy has been effectively used as a relatively inexpensive and non-invasive method of treating neonatal hyperbilirubinemia through photooxidation. A conventional phototherapy lowers serum bilirubin levels by using halogen or fluorescent light to transform bilirubin into water-soluble isomers that can be eliminated without conjugation in the liver. During phototherapy, the baby is undressed so that as much of the skin as possible is exposed to the light, and her eyes are covered to protect the nerve layer at the back of the eye, which is the retina, from the bright light, and the bilirubin level are measured at least once a day. Alternatively, fiberoptic Alternatively, fiber optic phototherapy is also available via a blanket called Bilai blanket that consists of a pad woven fibers used to transport from a light source to the baby's back. The light generated through the Bilai blanket. The light generated through the Villi blanket breaks down the bilirubin through photooxidation. The dose of phototherapy is a key factor in how quickly it works, and the dose is determined by the wavelength of the light. The intensity of the light, irradiance, the distance between the light and the baby, and the body surface area exposed to the light. Commercially available phototherapy systems include those that deliver light via fluorescent bulbs, halogen quartz lamps, light-emitting diodes, and fiber optic matrices. In extreme cases of hyperbilirubinemia, an exchange transfusion may be used as a second-line treatment when phototherapy fail. An exchange transfusion involves removing aliquots of blood and replacing it with donor blood in order to remove abnormal blood components and circulating toxins while maintaining adequate circulating blood volume. Is it because hyperbilirubinemia is so serious in newborns? Bilirubin levels are carefully and frequently monitored so the dangerously high level of a conjugated bilirubin, approximately 20 milligram per DL can be detected and treated appropriately. Last but not least is the posthepatic jaundice. A posthepatic jaundice results from biliary obstructive disease, usually from physical obstruction, gallstone, or tumors that prevent the flow of conjugated bilirubin into the bile canaliculi. Since the liver cell itself is functioning, bilirubin is effectively conjugated. However, it is unable to be properly excreted from the liver. Since bile is not being brought to the intestine, stool loses its source of normal pigmentation and becomes clay-colored. The laboratory findings for bilirubin and its metabolites in the above mentioned types of jaundice are summarized in table 25.1. In figure 25.6 is the mechanism of the hyperbilirubinemia. We have here the letter A is the normal bilirubin metabolism, as we can see here. And B, hemolytic jaundice. C, a Gilbert disease physiologic jaundice. E, Darwin-Johnson syndrome. And lastly is the intrahepatic or extrahepatic obstruction. Moving on to the next disease, which is the cirrhosis. A cirrhosis is a clinical condition in which scar tissue replaces normal healthy liver tissue. As the scar tissue replaces the normal liver tissue, it blocks the flow of blood through the organ and prevents the liver from functioning properly. Cirrhosis rarely causes signs and symptoms in its early stages, but as liver function deteriorates, the signs and symptoms appear, including the fatigue, nausea, unattended weight loss, jaundice, bleeding from the gastrointestinal tract, intense itching, and swelling in the legs and abdomen. Although some patients with cirrhosis may have prolonged survival, they generally have a poor prognosis. And cirrhosis was the 12th leading cause of death by disease in 2013, killing just over 36,400 people. In the United States, the most common cause of cirrhosis is chronic alcoholism. Other causes of cirrhosis include chronic hepatitis B, HBV, C, HCV, and D virus, which is the HDV infection. Autoimmune hepatitis, inherited disorders, example, the A1 antitrypsin deficiency, Wilson disease, hemochromatosis, and galactosemia. And lastly, the non-alcoholics steatohepatitis, black bile, drugs, toxins, and infections. A liver damage from cirrhosis cannot easily be reversed, but treatment can stop or delay further progression of the disorder. But the treatment depends on the cause of cirrhosis and any complication a person is experiencing. For example, cirrhosis caused by alcohol abuse is treated by abstaining from alcohol. Treatment for hepatitis-related cirrhosis involves medication used to treat the different types of hepatitis, such as the interferon for viral hepatitis and corticosteroid for autoimmune hepatitis. Next disease is the tumors. Cancer of the liver are classified as primary or metastatic. A primary liver cancer is cancer that begins in the liver cells, while the metastatic cancer occurs when tumors from other parts of the body spread metastasize to the liver. A metastatic liver cancer is much more common than primary liver cancer. 90 to 95% of all hepatic malignancies are classified as metastatic. Cancer that commonly spread to the liver, including the colon, lung, and breast cancer. Tumors of the liver may also be classified as benign or malignant. And the common benign tumors of the liver include the hepatocellular adenoma, a condition occurring almost exclusively in females of childbearing age, and the hemangiomas, a masses of blood vessel with no known etiology. And we also have here the malignant tumors of the liver. First is the hepatocellular carcinoma, HCC, or also known as the hepatic carcinoma and the hepatoma, and the bile duct carcinoma. On those HCC, HCC is the most common malignant tumor of the liver. Hepatoblastoma is an uncommon hepatic malignancy of children. HCC has become increasingly important in the United States. Approximately 85% of the new cases of this liver cancer occur in developing countries, with the highest incidence of HCC reported in regions where HBV is endemic, such as the Southeast Asia and Sub-Saharan Africa. And approximately 500,000 people are diagnosed annually with HCC worldwide, of which 28,000 new cases and 20,000 deaths were reported in the United States and year 2012. And it is estimated that in the United States, chronic HBV and HCV infections account for approximately 30 and 40% of cases of the HCC. And approximately 80% of cases worldwide are attributable to the HBV and HCV. However, the mechanism by which the infection leads to HCC is not well established. While surgical resection of HCC is sometimes possible, currently orthotopic liver transplantation, currently orthotopic liver transplantation and people with HCC with underlying cirrhosis who meet the Milan criteria with a single tumor less than 5 centimeters in size or less than 3 tumors each at 3 centimeters in size and no macrovascular invasion is also available for HCC. And the estimated 4-year survival rate is 85%, and the recurrence-free survival rate is 92%, whether primary or metastatic. Any malignant tumor in the liver is a serious finding and carries a poor prognosis with survival times measured in months. Moving on to the next disease, the Reye syndrome is a term used to describe a group of disorder caused by infectious metabolic toxic or drug-induced disease found almost exclusively in children. Although adult cases of Reye syndrome have been reported. The precise cause of Reye syndrome is not known or unknown. It is often preceded by a viral syndrome such as the varicella and gastroenteritis, or an upper respiratory tract infection such as the influenza. Although not described as the precise cause Reye syndrome, studies have demonstrated a strong epidemiologic association between the ingestion of aspirin during a viral syndrome and the subsequent development of Reye syndrome. As a result, the Center of Disease Control and Prevention, CDC, cautioned physicians and parents to avoid salicylate use in children with a viral syndrome. And the U.S. Surgeon Clinic General mandated that a warning level be added to all aspirin-containing medication beginning in 1986. A Reye syndrome is an acute illness characterized by a non-inflammatory encephalopathy and fatty degeneration of the liver, with a clinical presentation of profuse vomiting accompanied with a varying degrees of neurologic impairment, such as the fluctuating personality changes and deterioration, and consciousness. The encephalopathy is characterized by a progression from mild stage 1 through progressive loss of neurologic function to loss of brain stem reflexes to stage 5. And the degeneration of the liver is characterized by a mild hyperbilirubinemia and threefold increase in ammonia. And the aminotransferases, aspartate aminotransferases, AST, and alanine aminotransferases, the ALT. Without treatment, rapid clinical deterioration leading to death may occur. Down to the last disease, which is a drug and alcohol-related disorder. The liver is a primary target organ for adverse drug reaction because it plays a central role in drug metabolism. Many drugs are known to cause liver damage ranging from a very mild transient forms to fulminant liver failure. Drugs can cause liver injury by a variety of mechanisms, but the most common mechanism of toxicity is via an immune mediated injury to the hepatocytes. And in this type of mechanism, the drug induces an adverse immune response directed against the liver itself and results in hepatic or cholestatic disease. Of all the drugs associated with hepatic toxicity, the most important is the ethanol. Ethanol. In very small amounts, ethanol causes very mild, transient, and unnoticed injury to the liver. But however, with heavier and prolonged consumption, it can lead to an alcoholic cirrhosis. While the exact amount of the alcohol needed to cause cirrhosis is unknown, a small minority of people with alcoholism develop this condition, and approximately 90% of the alcohol absorbed from the stomach in small intestine is transported to the liver for metabolism. Within the liver, the elimination of alcohol requires the enzyme alcohol dehydrogenase and acetaldehyde dehydrogenase to convert alcohol to acetaldehyde and subsequently to acetate. The acetate can then be oxidized to water and carbon dioxide, or it may enter the citric acid cycle. But the long-term excessive consumption of alcohol can result in a spectrum of liver abnormalities that may range from alcoholic fatty liver with inflammation, steatohepatitis, to scar tissue formation, as in hepatic fibrosis, to the destruction of normal liver structure seen in hepatic cirrhosis. An alcohol-induced liver injury may be categorized into 3 stages: the alcoholic fatty liver, alcoholic hepatitis, and the alcoholic cirrhosis. And the risk for the development of cirrhosis increases proportionally with the consumption or more than 30 grams, equivalent of 3 to 4 drinks of alcohol per day, with the highest degree of risk seen with the consumption of greater than 120 grams, equivalent of 12 to 16 drinks per day. An alcoholic fatty liver represent the mildest category where very few changes in liver function are measurable. And this stage is characterized by slight elevation in AST, ALT, and Y-glutamyltransferase or the GGT. And on biopsy, fatty infiltrates are noted in the vacuoles of the liver. And this stage tend to affect the young to middle-aged people with a history of moderate alcohol consumption. A complete recovery within a 1 month is seen when the drug is removed. Next is the alcohol. Next is the alcoholic hepatitis. An alcoholic hepatitis presents with the common signs and symptoms including the fever, ascites, proximal muscle loss, and more laboratory evidence of liver damage such as the moderately elevated AST, ALT, GGT, and alkaline phosphatase ALT, and the elevation in total bilirubin greater than 5 mg per dl. The elevation in EST are more than twice the upper reference of normal, but rarely exceed 300 IU per ml. The elevation in ALT are comparatively lower than AST, resulting in AST-ALT ratio, the Diritis ratio, greater than 2. Serum protein, especially the albumin, are decreased, and the international normalized ratio, which is the INR, which is ratio of coagulation time in the patient compared with the normal coagulation time, is elevated. The prognosis is dependent on the type and severity of damage to the liver. And when serum creatinine level begin to increase, it is threatening again. It is a threatening sign, which may precede the onset of hepatorenal syndrome in death. And there are a variety of scoring systems that have been used to assess the severity of alcoholic hepatitis and to guide treatment, including the Manual discriminant function, the Glasgow score, and the model for end-stage liver disease score, or the MELD or MELD. And all those three scoring systems use the bilirubin, INR, creatinine, age, white cell counts, blood urea nitrogen, and albumin level to stage and guide treatment. The last and the most severe stage is the alcohol cirrhosis. The prognosis is associated with alcohol cirrhosis is dependent on the nature and severity of associated conditions such as the gastrointestinal bleeding or ascites. However, the 5-year survival rate is 60% in those who abstain from alcohol and 30% in those who continue to drink. And this condition appears to be more common in males than in female since, yeah. And the symptoms tend to be non-specific and include the weight loss, weakness, hepatomegaly, splenomegaly, jaundice, ascites, fever, malnutrition, and edema. For laboratory abnormalities, it includes the increased liver function test, AST, TGT, ALP, and the total bilirubin, decrease in albumin, and the prolonged prothrombin time. A liver biopsy is the only method by which a definitive diagnosis may be made. Other drugs, including the tranquilizers, some antibiotics, antineoplastic agents, lipid-lowering medication, and anti-inflammatory drugs may cause a liver injury ranging from a mild damage to massive hepatic failure and cirrhosis. And one of the most common drugs associated with the serious hepatic injury is the acetaminophen. When the acetaminophen is taken in massive doses, it is virtually certain to produce fatal hepatic necrosis unless rapid treatment is initiated. And that's all, ma'am, for the liver functioning alteration during this. For the continuation of this topic, we will have the part 2.